Paul actually will lead off this session by looking at MR guidelines for quantitation. And I know he has strong opinions about that.
I do have strong opinions, and so do you. So in fact, Bill is chairing the committee, a writing committee of the ASE to update these guidelines. And so I'm not able to share those with you. Steve is on that committee. It's probably early next year will be in print, but we'll talk about some of the things that are current. I do have disclosures that I work with all the companies that make devices that go in the mitral valve. I want to start with this. So I was on an ACC committee to identify the issues in MR, and we did some surveys, and basically what we realized is that there's a lot of problems in managing patients with MR, and they depend on the quality of imaging not being very good and being very variable, to people not knowing whether their surgeon can repair a valve or not. I'm not going to go into all of this, but I'm going to kind of focus on this, that imaging is not uniform, it's variable, it's hard to do. We even discovered in our survey that most people don't even really know the difference between primary or secondary MR. Less than half of physicians indicated high confidence in detecting MR. We showed some straightforward images to a group of cardiologists and surgeons. 14% could not identify secondary MR. They thought it was prolapse. And we showed a simple case of posterior leaflet prolapse, and 30% didn't get that right. 20% couldn't identify the quantitative criteria for identifying severe MR. So we've got some real issues that we need to do in terms of education. That also comes to the sonographer level, where a lot of sonographers really don't understand the quantitative things and don't do them. Most people out there still do eyeball assessment of how much MR there is, even though the guidelines have deemed it to be unreliable when used in isolation. And then again, more problems here about just interpretation, all kinds of issues with people not measuring things that are in the guidelines that are listed here. You can see all of this. So there's issues, and then the guidelines sort of came out about valve disease, and there's some issues there too. I think these are all just highly respected, very smart people, but they came out with something that I think is important, and that is staging this disease just like we do with heart failure. So, stage A, you're at risk, but you don't really have regurgitation. So maybe you have mitral valve prolapse or a non-ischemic cardiomyopathy, but you've not really developed, MR yet. And then progressive is you have mild or moderate, but you're asymptomatic. And then you get to severe MR, where you're either asymptomatic with or without LV dysfunction, or you're symptomatic. But the key here is, if we're going to do this disease staging, we have to be able to accurately tell whether you're mild or moderate or whether you're severe. So the guidelines say that the classification of severity of valve lesions should be based on multiple criteria. I think we all agree with that. No one criteria is good enough. There is almost unanimity of opinion on that. And then the other thing that they said is that the criteria for defining severe is based on the natural history of unoperated valve disease, as well as observational studies relating the onset of symptoms to measures of severity. I don't agree with this. What they're basically saying is what determines severe is prognosis. And I don't think that's true. Traditionally in medicine, severe means a lot of something, and mild means not very much of something. Well, I would rather have severe alopecia than mild or small pancreatic cancer. Just a little bit of pancreatic cancer carries a bad prognosis. Severe alopecia doesn't. So I think this jumbling of the definition of volumetric severity and prognosis they need to be kept separate and not confused. Now let's talk about the color flow jet. So here's I made this slide years ago, but I still use it. I went out in my backyard, turned on the water hose. Okay, there's constant flow coming out of this hose, right? And there's an orifice that's round. I then put my thumb over here and make a slit-like orifice that's smaller, and guess which one has the bigger jet? Put a Doppler probe through there. It's an imaginary probe, of course. And this one, you have a little bitty jet, and this one, you have a gigantic jet. And this is just to illustrate that the size of the jet doesn't have anything to do with flow volume. It has a lot to do with the spatial distribution of velocities. And I am shocked that nobody seems to know this simple basic physics thing. So you can be, somebody can come in with a blood pressure of 180 over 90 and have a huge MR jet because it looks like this. And so really, we want to pay attention not so much to how big the jet is down here, but how wide it is here. That's what's going to be important. It's the size of the hole, not the size of the jet. So I have to show this. You know, I'm now old. I've been doing this for 30 years, so now I can say things like this. One of the things that I've found in medicine over a 30-year career is that when something gets in the literature that's kind of weak, but it's put in there, it gets propagated. And then you can't go back and fix it. It's just propagated. So this is the data, this is the paper on which these numbers for EROA and regurgitant volume come from. It comes from this paper. It was published in Circ in '97. I was one of the reviewers. And what they did, this is a Mayo Clinic, they took a bunch of people that were going to the cath lab, and they compared angiographic grade, you know, which we all know has issues, to ERO and regurgitant volume by quantitative Doppler and or PISA. And what they typically did is they averaged the two, or they did one or the other, depending on technical quality. So then they had the statistician look, and these little blue boxes down here show the cutoffs. The statistician said the best cutoff for distinguishing angiographic grade is 20, 30, and 40 for EROA, and 30, 45, and 60 for regurgitant volume. But what I want you to look at, which should be obvious, is the overlap in patients, you know. And so while in group data, the statistician is right, those numbers are meaningful cutoffs, you could take a patient down here and he could be mild, he could be 1+, 2+, 3+, or even 4+, because there's a lot of overlap in these values, especially here, you know. When you have a really huge EROA or regurgitant volume, that's probably pretty specific for severe MR. But sensitivity is a problem here, as you can see. Yet this has been propagated forever, and it gets propagated into the guidelines. So I'm not going. This chart, I realize, is hard to read, so I'm going to focus on this and blow it up. Regurgitant volume is 60, regurgitant fraction 50, EROA of 40. Is angiographic 3 and 4+, according to this. But according to the paper I just showed you, 3+ is 0.3. 45 and 40 is 4+. So there's a little discrepancy there between the ECHO guidelines and the ACC guidelines about what is what. Because in the ACC guidelines, 3+ is severe and 4+ is severe. Secondary MR, they changed it to an ERO of 20, regurgitant volume of 30, and regurgitant fraction of 50, which again they say angiographic 3 and 4+. Well, that's a discrepancy. 3 and 4+ is not 20, 30, 20, you know. And Dr. Zogby and I and others have written complaining editorials about this. This is one that Tom Marwick, Dr. Zogby, and Narula wrote. And pointing out correctly that this is confounded. You know, when you're dealing with a patient with functional MR who has an adverse prognostic event, you don't really know whether it's the MR doing it, could be, you know, or whether it's these other things, LV dysfunction, scar, remodeling, you know, elevated left atrial pressure from the LV dysfunction. It's confounded, and so it's really hard to do that. So I and others wrote a similar paper, and here's what we focus on. Because I'm a simple guy, I like to go back to math. 2 + 2 is always 4. The math is good. It helps you understand things. Well, it turns out that if you look at the formula, the EROA is really related to the total stroke volume of the LV. And you can change that because we don't think that way, we'll just change it to end diastolic volume. So I've plotted end diastolic volume and EROA, assuming an EF of 30, sort of a typical functional MR, and a regurgitant fraction of 50, which all guidelines say is severe. And if you do this, the plots kind of depend on the velocity. It would really be VTI, but to make it simple, peak velocity of 4, peak velocity of 5, peak velocity of 6. Now what happens is if you look at this prognostic data, that should be, the 2 should be up here, but if you're at a small ventricle, an EROA of 0.2 would give you a regurgitant fraction of 50%. If you're here, 0.3, and if you're here, 0.4. And in other words, there's not one ERO that's always severe. It depends on the stroke volume of your ventricle. And so if you look at the studies that have looked at outcomes, this is the Lancelotti study. This is the only one quoted in the European guidelines as saying that an ERO of 2 predicts adverse prognosis. And the same kind of goes in the US guidelines. They sort of conveniently left out a lot of studies, which is bad science. Shouldn't do that. If you look at these studies, this is the best trial. I was the Echo Core Lab for that, so I know this data. This is where most heart failure trials are. You look at Companion or the CRT trials, any of the heart failure trials, the end diastolic volumes are in the 200 to 250 range, and where 0.3 would be. There was a very famous, you start looking at all these studies, they line up right along the curve where they should be. This study from the Mayo Clinic showed specifically that an ERO of 0.2 did not predict outcome in functional MR. This was their heart failure transplant group where the ventricles are huge and you wouldn't expect it to. So picking a number and jumping on it is wrong. You can't do it that way. You have to look at everything. Caveats, there's a lot of them. MR may not be holosystolic. You saw that this morning from Dr. Little. Small errors in Pisa radius or squared. Orifice shape affects measurements. You have to pay attention to the hemodynamics, the shape, density, and velocity of the CW jet, pulmonary veins, mitral inflow, LA and LV size. You've already heard some of that this morning. I'll show you some examples of different things. This is 2 different jets. Some people really like to rely on whether the jet comes all the way back. As I told you, I don't really care about that. But if you look, this jet is very turbulent down here. This one's not. It's low velocity here. And then if you look at the pulmonary vein pattern, in this one there's systolic flow reversal. In this one it's completely normal. This is mild MR. I don't care if the jet touches back here. This is severe MR, and this is very wide here. This is a little skinny jet here. You have to look at lots of things. Here's another thing to look at. Pay attention to the peak velocity. So you have 2 jets that look alike, okay? They both kind of a little bit eccentric. They kind of hug the wall. They look very similar. And when you do the EROA on this one, it's 0.3, which is a lot of MR, 42 for regurgitant volume. Over here, it's less than 0.1 with the regurgitant volume of 17. It's mild. The difference here is pay attention to the velocity. If you have a velocity of 4, you've got a mean gradient. You convert that to a gradient, it's 64. So if you've got a blood pressure of 100 minus 64, your LA pressure is 36. That's bad. When you see these low velocities in MR, that's bad. It means your LA pressure is probably high. When you see high ones, like 6.4, that's going to be a gradient of 160. So if you have a blood pressure of 170 minus 160, your LA pressure is 10. That's what is going on here. Nobody pays attention to these velocities, but they tell you a lot about what's going on with the patient. And low is worse. Most of the time, it's going to be 5. I showed you 2 examples that are a little different just to make the point, but pay attention to that. You've already seen this, single frame measurements, really confusing. This is a 26-year-old woman who I saw in clinic. She was sent to me, told that she needed mitral valve surgery. She was scared to death. She runs a 5K 3 times a week. She's fine. Hardly has a murmur. No MR. Look at the EKG. Early systole, not a drop of MR. Mid-systole, not a drop of MR. The tail end of the T wave, she has this big poof of MR, and you can see it's late systolic. For the sonographers here, do not turn up the gains and force this into a holosystolic signal. You can do that. Please don't. Just recognize that non-holosystolic MR is a problem. This is the same frame, no difference. These two pictures are the same, but if I measure the radius at 0.7 here, I get an ER of 0.16 and a regurgitant volume of 30, mild MR. If I measure it at 8, I get 0.26 and 42, moderate MR. So these measurements are difficult. And finally, don't compare apples to oranges. My mom told me that a long time ago, but really don't compare oranges to bananas. That's the point. The PISA formula works for a hemisphere. That's a hemisphere. It doesn't work for a hemi-banana, okay? And you already saw this from Steve Little. Here's an example, a TEE I did. ERO was 0.25, but when we do 3D and you see the hemi-banana here, the ERO is really 0.5. And so you have to pay attention to that. There's a lot of studies comparing 3D vena contracta area to some reference standard, and they actually work out to be pretty reasonable. I want to show you one thing that's interesting. In secondary MR, it's another one of my fun math slides. And here we're going to assume a VTI of 168, because that was the mean VTI in the BEST trial, and EF of 30. Here's the end-diastolic volume. You can see that you could have severe MR with an ERO of 0.2. As you get towards smaller ventricular sizes, you would have that. But an ERO of 0.5 is hard to get in functional MR because, only, at a ventricle below about 250, you would have more than 100% of your flow going backwards, and you can't be alive with that. So you have to actually think about ERO and regurgitant volume in terms of total stroke volume and LV in diastolic volume. If you come up with a number of 0.8, that's impossible. You'd have a regurgitant fraction of 200%. You can't do that. Mathematically impossible. So let's conclude. Pay attention to the mechanism of MR. Integrate multiple clinical, hemodynamic, and imaging parameters to grade it. Don't be married to a single number in a table. You'll end up divorced. And then moderately severe MR is usually severe, especially in FMR or when there are other specific findings. We see all the time flail leaflet with an ERO of 0.3 and pulmonary vein flow reversal. So think about these things. Integrate, integrate, integrate. Thank you.